Be safe, everyone. My task for today is to show you a video on the neurological examination based on the Bates Visual Guide to Physical Examination. So, as an introduction, anatomy and pathology of the nervous system is understood by directly visualizing it. And this is best accomplished by handling the brain or the model of the brain and dissecting or taking it apart for direct examination. Now, the purpose for the clinician of understanding neuroanatomy and neurophysiology is to be able to use that knowledge to solve clinical problems. And the first step in solving a clinical problem is anatomical localization. So, if one cannot directly inspect the patient's brain, how is this localization accomplished? Now, the window to the patient's brain is the neurological examination. The neurological examination is a series of tests and observations that reflects the function of various parts of the brain. If the examination is approached in a systematic and logical fashion that is organized in terms of anatomical levels and systems, then the clinician is led to the anatomical localization of the patient's problem. Now this slide will show you the different parts of your neurological examination. The first part is examination of the mental status or cerebral function, followed by examination of the cranial nerves, the motor, cerebellar including the gait, the reflexes, also including the pathological reflexes, sensory, as well as your meningeal irritation signs. Now, in the next slide that you will be seeing, the mental status examination was intentionally omitted.
This video begins with a brief overview of health history taking, followed by general observations of neurologic status, anatomy of the cranial nerves, examination of cranial nerves 1 through 12, The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you will record the patient's chief complaint, along with common or concerning symptoms. Common or concerning symptoms relating to the nervous system and which are specific to cranial nerves and the motor system include changes in mood, attention, or speech, changes in orientation, memory, insight, or judgment, delirium or dementia, headache, dizziness or vertigo, loss of consciousness, syncope or near syncope, seizures, and tremors or involuntary movements. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. Three important questions will govern your neurological examination of the cranial nerves and the motor system. Is the mental status intact? Are right-sided and left-sided findings symmetric? And if the findings are asymmetric or otherwise abnormal, Does the causative lesion lie in the central nervous system or the peripheral nervous system? To enhance efficiency, you may wish to address the first of those questions here during your health history taking. Specifically, now is a good time to observe the patient's mental status, including appearance and behavior, speech and language, mood, memory, and orientation.
Okay, well, I'm going to take a look at you.
With the patient's health history in mind, you are now ready to continue your examination. Before continuing, however, let's briefly review the location of the cranial nerves within the peripheral nervous system. The peripheral nervous system includes 12 pairs of cranial nerves that emerge from within the skull. Cranial nerve 1 emerges from the cerebral hemisphere, whereas cranial nerves 2 through 12 arise from the diencephalon and brainstem. The cranial nerves mediate complex motor and sensory functions. Several of the cranial nerves are specialized, producing smell, vision, or hearing. To examine the cranial nerves, you may begin with cranial nerve 1, the olfactory nerve, which mediates the sense of smell. Typically, however, cranial nerve 1 is not tested unless a neurological problem is suspected. If you do assess its function, first be sure both nasal passages are patent.
Can you smell what this smell is?
Then, with one of the patient's nostrils occluded and his eyes closed,
Cinnamon.
Right.
pass a mildly aromatic and familiar substance such as vanilla, cloves, cinnamon, or coffee under the open nostril. If the patient detects the smell, ask him to identify it.
Can you smell that smell? Can you tell me?
Repeat the olfactory test on the other side.
Clove.
Normally,
Right.
the patient should perceive
open your eyes.
odor on each side, even if unable to identify it.
I'm going to test your visual acuity next.
Cranial nerve 2, the optic nerve, mediates vision. To assess its function, check the patient's visual acuity and visual fields, and inspect the optic fundi.
Do you wear glasses or contact lenses?
No.
If the patient does require corrective lenses, he should wear them.
Take that card in your other
If a
hand.
Snellen chart is not available, test visual acuity by using a special handheld eye card. To do this, ask the patient to cover one eye,
Good.
hold the card where he is most comfortable, and read aloud the smallest print
Read
possible.
the same row of numbers?
937826.
Good.
For screening purposes, visual fields are tested by confrontation. Face the patient directly and imagine a glass bowl encircling his head. Ask the patient to look with both eyes into your eyes.
You look right at the bridge of my nose.
Then place your hands about 2 feet apart, lateral to the patient's ears.
Wiggling.
Both sides?
Slowly move the wiggling fingers of both hands along the imaginary bowl until the patient identifies them.
Wiggling.
Both sides?
Yes.
And again. Tell me
Normally,
as
a
soon as
person
you see
sees
the wiggle.
both sets of fingers at the same time.
Both sides?
Yes.
Good.
Repeat this action in the upper and lower temporal quadrants. If you think you have found a visual
Now,
defect,
cover one
such
eye
as loss of vision in the right temporal field,
with your right eye.
slowly
Look
move
right
your
at my
wiggling
left eye.
fingers from the defective area of the
Don't look at
field
the finger, but tell
toward
me
the
if
better
it's still
vision.
wiggle.
Yes.
Repeat this at several
Tell me
levels
if it's still
until you can
wiggles.
define the border of the defect.
Okay, keep looking
Then
at this
test
eye.
the other eye for
See
an
that finger
accompanying
wiggling?
defect.
Yes.
Is it still wiggling as it comes up here?
Yes.
All right, change eyes.
Next, inspect each ocular fundus by using an ophthalmoscope. In general health care, you should examine patients' eyes without dilating their
You look
pupils.
off in the distance at a spot on that wall. Keep your eye fixed on the spot.
Inspect the optic disc. Note its color, the sharpness of the margins, and the width of the physiologic cup. Cranial nerves 3, 4, and 6, the ocular motor, trochlear, and adducens nerves, control eye movements.
Look right
Because these nerves work together so closely, they are examined as a group. The ocular motor nerve is also responsible for pupillary constriction and raising the upper eyelid. Check the position of the upper eyelids while the patient looks directly at you. The eyelids should be symmetrical and should not obscure the pupils. Next, inspect the pupils. They should be round and approximately equal in size. Size should be appropriate to room light. Test the pupillary reaction to light by shining a light on each pupil in turn. Observe for the direct reaction and for the consensual reaction. Patients with lighter irises often exhibit a consensual reaction that is seen more easily than in patients with darker irises.
Look at that finger.
Next, hold your finger or pencil about 10 centimeters from the patient's eyes, and then look for pupillary dilation in the patient's distant gaze.
Look back at the finger. Look back at the wall again.
Repeat this test if necessary.
Look at this finger now.
Next, check the extraocular movements in the 6 cardinal directions of gaze. Stand 2 to 3 feet in front of the patient. Ask him to follow your finger or a pencil as you make a wide H in the air. These movements should be symmetrical and conjugate. Look for the jerky movements of nystagmus in lateral gaze and in upward gaze. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of his nose. Eyes can usually follow your finger to within 5 to 8 centimeters. The motor portion of cranial nerve 5, the trigeminal nerve, innervates the muscles of mastication. The sensory portion of the nerve mediates facial sensation and the sensory part of the corneal reflex. To test the nerve's motor function, ask the patient to clench and then relax his jaw while you palpate the temporal muscles and then the masseter muscles.
Clench again.
Note the strength of muscle contraction.
And relax.
The sensory portion of the trigeminal nerve has 3 divisions: the ophthalmic, maxillary, and mandibular divisions. All 3 areas should be tested symmetrically by assessing the patient's sensation to pain, light touch, and, if indicated, temperature. Begin by explaining to the patient how you will assess for pain.
I'm going to use this broken Q-tip and I'm going to test sharp and dull.
With the patient's eyes closed, test for pain sensation using the sterile, sharp end of a broken cotton swab stick, a previously unused safety pin, or some other suitable sharp object to stimulate the patient's forehead and cheeks at the points indicated. Occasionally, substitute the dull end for the sharp one as you test scattered areas. Compare symmetrical areas on both sides of the face. If you suspect an abnormality, confirm it by testing further for temperature sensitivity.
Is this the same as this?
Same.
Now I'm going
Next,
to
test for light touch using a wisp of cotton. Test in scattered areas. Again, compare sides.
Now. 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 Now.
Now I'm going to compare the sides. You keep your eyes closed and tell me if they're the same or different. Is this the same as this?
Yes.
To test the corneal reflex, ask the patient to look up and away from you. Now, approach the patient from the side out of his line of vision and lightly touch the cornea with a fine wisp of cotton. Normally, the patient's eyes blink and tear. However, contact lens wearers may have diminished or absent corneal reflexes. Cranial nerve 7, the facial nerve, innervates all the muscles of facial movement and expression. It also mediates taste sensation in the anterior two-thirds of the tongue. To assess this nerve, inspect the patient's face at rest and during conversation. Note any asymmetry and look for tics or other involuntary movements.
All right. Now I'm going to ask you to perform some facial expressions.
Okay.
First, raise your eyebrows
Next,
up strong.
ask the patient to raise his eyebrows.
Now make a frown.
Frown.
Okay.
Close his eyes
Now
so
close
tightly
your
that
eyes.
you can't open them.
Hold them really tight.
Show his
All right,
teeth.
relax. Now, show me your teeth.
Smile.
Relax. Now smile.
And puff out his
Relax.
cheeks.
Now puff your cheeks out.
Normally, the patient can do these maneuvers easily and
All right,
symmetrically. Cranial nerve 8, the acoustic nerve, mediates hearing and vestibular function. Because vestibular function is not routinely tested, our exam will focus on hearing. To assess hearing, test one ear at a time.
Now I'm going to whisper.
Occlude one of the patient's ears with your finger.
I'll start very softly.
Stand 1 to 2 feet away from the patient
As soon as it becomes
and
audible,
conceal your mouth
you
to
say
prevent
what it
lip
is.
reading.
Okay.
Exhale fully to minimize the intensity of your voice. And test the open ear by softly whispering numbers or words that contain equally accented syllables, such as 99 or baseball.
Baseball.
Right. Now I'm going to do a different word in this here.
Gradually increase your volume until the patient can identify your words. Repeat on the other side. If hearing is
Barbell.
diminished,
Right.
test for lateralization by performing the Weber test. To do this, place the base of a vibrating tuning fork
Now I'm gonna
firmly
test
on
your
top
hearing.
of the patient's head. Then ask if the sound is louder
do
in
that?
one ear or the same in both
Is it
ears.
the same in both ears or louder in one?
The same in both ears.
Normally, the sound is heard midline or equally on both sides. Next, compare air and bone conduction by performing the Rene test. Place a lightly vibrating tuning fork on the mastoid bone behind the ear. When the patient indicates that the sound is no longer heard, quickly place the vibrating fork near the ear canal.
Do you hear it now?
Normally, the patient can hear the sound longer through air than through bone. Be sure to test the opposite ear.
Do you hear that buzz?
Yes.
Tell me when it stops.
Now?
Do you hear it now?
Yes.
Cranial nerves 9 and 10, which are the glossopharyngeal and vagus nerves, mediate the sensory and motor functions of the palate, the pharynx, and the larynx.
Now I'm going
To
look
test
into the
these
back of your
nerves,
throat.
ask the
Open your
patient
mouth,
to
please.
say ah or yawn.
Say ah.
Assess the patient's voice. Is it hoarse? Does it have a nasal quality? Observe the soft palate and the uvula. The soft palate should rise promptly and symmetrically, and the uvula should remain midline. Then inspect the interior and posterior pillars and the pharynx. Next, test the gag reflex
Check your
one
gag
side at a
reflex.
time.
First on the left. Open again.
Using a tongue blade, and after warning the patient, stimulate the back of the throat lightly on each side in turn. You should see a prompt rise of the palate and other signs of gagging. Ask the patient to swallow.
Now swallow, please.
It should be done without difficulty or regurgitation. Cranial nerve 11, the spinal accessory nerve, innervates the sternomastoid and upper trapezius muscles. For this assessment, open the patient's gown in the back to reveal the upper trapezius muscles. Ask the patient to shrug his shoulders upward against your hands.
Put your hands in front. Turn your head straight ahead and shrug your shoulders up, please.
During this maneuver,
Hold them up.
evaluate the strength and contraction of the
All
trapezius
right, good.
muscles.
Now turn your
From
chin
in front of
into
the
my
patient,
hand.
ask the
Turn it
patient to
strong.
turn his head to each side against your hand. Observe the contraction of the opposite sternomastoid
Now
muscle
turn your chin into my
and
hand
notice the
afterwards.
force of the movement against your hand. Cranial nerve 12, the hypoglossal nerve, mediates the tongue's motor functions, which in turn affect articulation of words. Inspect the patient's tongue as it lies on the floor of his mouth.
Open your mouth,
Observe
please.
for atrophy and fasciculations. There should be none.
Now stick your tongue out.
Ask the patient to stick out his tongue. Note any asymmetry or deviation from the midline. The tongue should protrude
All right.
straight out. Let's briefly review the anatomy of the motor system. Motor activity requires the combined and coordinated interaction of the cerebellum, upper motor neurons, which are part of the central nervous system, lower motor neurons, which are part of the peripheral nervous system, and the muscles. To examine the motor system, first disrobe the patient so that the largest group of muscles can be observed and examined. Fold down the patient's gown to reveal the muscles of the patient's upper torso, and adjust the lower portion of the gown to reveal the muscles of the patient's legs. Look for abnormal movements or
You
atrophy.
just relax with your hands, right?
Inspect
like this.
and palpate the individual muscle groups in the arms and legs. Watch for involuntary movements in the legs, or look for fasciculations or areas of atrophy. Then evaluate the patient's muscle tone or resistance to passive stretch. Encourage the patient to relax.
All right. Now you just relax. Let me do the work.
Take one hand in
Arms
yours,
and hands around.
and while supporting the elbow, flex and extend the patient's fingers, wrist, elbow, and shoulder in one coordinated movement.
On this side.
The patient's arm should move easily and smoothly with little resistance.
Okay. Same in the legs now.
To
You
assess
just
muscle
relax.
tone in the legs, extend the patient's leg at the knee and move the foot up and down at the ankle. Note the patient's resistance to your movements. Assess both legs in turn. You will grade your patient's muscle strength on a scale of 0 to 5, with 0 indicating no muscular contraction detected, and 5 indicating active movement against full resistance without evident fatigue. This is considered a normal response. In your assessment of the patient's muscle strength, ask the patient to move actively against your resistance. If the patient is too weak, test the muscles against gravity or with gravity eliminated.
First, pull towards you. Strong.
Begin by testing flexion of the biceps
Now
muscle
here.
and extension of the triceps by having the patient bend his arm at the elbow and pull, then push against your hand.
Here.
Usually the patient's
away.
dominant side is stronger than the non-dominant side.
Good. And here, push the arm out. Strong.
Next,
Good.
test flexion and extension of the patient's wrists.
Now put your wrists up like this. Hold them up strong. Good. Okay. Now make a fist and push your wrists down. Hold them down strong. Okay. Hold that one down strong. Okay, put them down.
Next, test the patient's grip.
Now, grab
Cross
my
your
fingers
middle
in your
and
hands
index fingers to
squeeze
cushion them.
Strong,
Then ask the
strong,
patient to squeeze as hard as
strong,
possible
strong.
while you try to remove your
Okay,
fingers.
good.
Normally, you should have trouble removing them.
Now spread your
Continue
fingers open
testing muscle
like
strength
this.
by
Hold
asking
them
the
open
patient
strong.
to turn his palm down and spread his fingers. Check
Strong.
abduction by trying to force them together.
Good. Okay. Now turn them over like this. Touch each thumb to the tip of the little finger.
Test opposition of the thumb by asking the patient to try to touch the tip of his little finger with his thumb while you resist the movement.
Next, I'm going to test
Examination of the motor
legs.
system of the lower extremities is best performed with the patient lying supine on the examination table. First, assess muscle strength in the legs. Test hip flexion by the iliopsoas muscle by placing your hand on the patient's anterior thigh and providing resistance.
You hold it there. Don't let me push it down. All right, good. Put it down.
Then test hip extension by the gluteus maximus
This leg right
by
here.
placing your hand on the patient's posterior thigh and providing resistance.
Now push it down against my hand strong.
To test hip abduction by the gluteus medius and gluteus minimus, place your hands firmly on the table outside the patient's
Now
knees.
I'm going to put my hands
Ask him to
outside the
spread
legs.
both legs against your hands.
Push your legs out against my hands. Ready? Push.
To test the hip abductors, place your hands between the patient's
Inside your
knees
legs. I want you
and
to
ask
push
him
your
to bring his legs together.
Strong.
Note the strength.
Ready? Push. Good.
Continue by testing muscle
I'm gonna
strength
bend
at the
this
knee.
leg right like this. You hold it right there. Don't let me push the foot down. Hold it there strong.
To assess quadriceps extension, support the patient's knee in flexion and ask him to straighten his leg against your hand.
Now let me bend
Note
this
the
leg a
strength
little bit.
and compare with
Get
the
out.
other side.
Now you keep it in that position. Don't let me push the foot down. Okay, good. Put it down.
To assess knee flexion by the hamstrings, shift your hand position but leave the patient's leg flexed at the knee.
Don't let me pull that heel off the table. Hold it strong.
Then ask the patient to keep his heel on the table
Straighten it out.
as you try to straighten the leg by pulling it upward. Again, note the
I'm gonna
strength
bend this knee
and
again.
compare it with the other
You
side.
keep the heel on the table. Don't let me pull the heel up. Good. Put it down.
Finally, test dorsiflexion and plantar flexion at the ankle by asking the patient to pull up and push
Now
down
pull the
against
foot
your
and
hand.
toes up towards you. Hold them up there strong. Don't let me push them down. Good. Now pull this foot and toes up towards you. Way up, strong. Hold them up there strong. Okay, relax. Now push this foot and toes down. And hold it down strong. Don't let me pull it up.
All of these tests can also be performed with the patient seated.
Relax. Don't
In such cases, the patient may try to hold on to the table for support, but that should be avoided because it tends to disguise the true strength of the patient's lower extremities.
Now this one.
Hip flexion,
Good. Strong.
hip abduction,
Okay. Against my fist.
hip adduction,
There.
knee flexion,
Against my hand.
knee extension,
Get out. Strong.
ankle plantar flexion,
Okay.
and ankle dorsiflexion.
Hold it up strong.
To assess coordination, you'll evaluate rapid alternating movements and point-to-point movements. Begin by showing the seated patient how to move his hands so you can assess rapid alternating movement of the arms.
I want you to do like this. over and back, over and back, over and back. Now you do it.
Observe the speed, rhythm, and smoothness of the movements.
All right?
Assess each arm in this way.
Over and back.
The patient's dominant hand may be better coordinated.
Good.
Now ask the patient to tap the distal joint of his thumb with the tips of his fingers in sequence.
Thumb in sequence. 1, 2, 3, 4. 1, 2, 3, 4. You do it.
Again, observe the movement, speed, rhythm, and smoothness.
Okay? Now with the left hand. Again, just like me, doing it. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. All right, good. Now with this finger, I want you to touch my finger. Touch it. Then touch your nose with that finger. Go back
Next,
and forth.
assess point-to-point movements. Move your finger continuously so that the patient has to change directions,
Now with
and
this
observe
finger,
the smoothness
I want you to
and
touch that
accuracy of pointing.
Then your nose.
Do this several
Back and
times.
forth.
Clumsy, unsteady, and inappropriately varying movements suggest cerebellar disorders.
Now with this finger, I want you to
Then,
put
with your
arm
finger
out
held steady in one place,
and make a
ask the
point.
patient to touch it,
Touch
then
my
raise his
finger
arm,
with it, and
then
bring
lower it
straight up
to
into
touch
the
your
air.
finger again.
Back down, touch my finger. Up again, back down, touch my finger. Once more, up, down, touch my finger. Close your eyes and keep doing it. Down, very good. Next,
To assess leg coordination,
tap with
ask
this
the
foot
patient
with the
to
palm of my
tap your
hand
hand as quickly as possible with the ball of each foot. Note any slowness or awkwardness. Compare
All right.
signs.
Down.
The feet
That
normally
foot.
perform less
Tap
well
with
than the
palm of your
hands.
hand rapidly. Okay, good. Now I want you to take this heel and run it down that shin bone in a careful straight line. Go ahead.
To test the heel to shin movement of the legs, ask the patient to place one heel on the opposite knee and then slide it down his shin to the big toe.
Good.
The patient should be able to do this
heel
smoothly
go down that
and
shin bone
accurately.
in a careful straight line.
Note any tremor or awkwardness.
And again.
Assess both legs.
Very good.
Continue the examination by observing the patient's
All right.
gait,
Now just walk
which provides
back and forth
information about coordination,
in your regular walk.
position sense, and muscle strength.
Turn and come back.
As the patient walks, observe his posture, balance,
Go again.
arm swing, and leg movements. The gait should be relaxed and balanced, with easy, alternating arm swings.
Turn again.
The face and head should lead the rest of the body on turns. Next, ask the patient to walk heel to toe in a straight line. This kind of gait, also called tandem walking, demonstrates cerebellar function and position sense.
All right, good. Now turn and go up on your tiptoes like that.
Then have the patient walk on his toes to test the strength of plantar flexion,
Okay. Now walk back on your heels.
and on
with
his
your toes
heels
pointed
to
up
test
like that.
dorsiflexion at the ankles. These actions also test balance.
All right, good. I'll come back to about here. Now, I want you first to hop on your right foot like this.
Next, ask the patient to hop in place, first on one leg
Okay,
and
good.
then the other.
Now hop on your
This
left.
ability indicates an intact motor system in the legs, normal cerebellar function,
Good.
and good
Stand
position
on your right
sense.
foot and do
Finally,
full knee
ask
bend
the
like
patient
that.
to do a shallow knee bend, first on one leg
Back up. Now on your
and
left
then
foot,
on the
knee
other.
bend.
The Romberg test primarily tests position sense. Ask the patient to stand with his feet together. Normally, he should be able to maintain this posture with his eyes open, indicating intact cerebellar function. Now have the patient do the same thing for about 20 seconds with his eyes closed.
Now close your eyes and keep your balance.
His posture should remain steady, with only minimal swaying, indicating intact position sense. If the patient maintains this posture with his eyes open, but not with his eyes closed, the Romberg test is positive, suggesting a cerebellar
Very good.
dysfunction.
Now open your eyes, stand normally. Put your arms out in front of you, palms up like this.
Now check for pronator drift by asking the patient to hold his arms forward and parallel with palms up, and to close his eyes for about 20 seconds. Normally, the patient can maintain this position, but watch for downward drifting of one arm and pronation of the forearm, which suggests mild hemiparesis.
Don't let them travel.
Finally, ask the patient to keep his arms up and eyes closed while you tap the arms briskly downward. Normally, the patient's arms return smoothly to the horizontal position.
All right, very good. You can open your eyes.
A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include language such as mental status, alert, relaxed, and cooperative, thought process coherent, oriented to person, place, and time, detailed cognitive testing deferred, cranial nerves, 1 not tested, 2 through 12 intact, motor system, good muscle bulk and tone, strength 5-5 throughout, cerebellar, rapid alternating movements, finger to nose, heel to shin intact, gait with normal base, Romberg maintains balance with eyes closed, no pronator drift. To summarize, the examination of the cranial nerves includes general observations of neurologic status, an examination of the cranial nerves 1 through 12, including assessment of the motor and sensory portions. The examination of the motor system includes assessment of body position, involuntary movements, muscle bulk, and muscle tone, assessment of upper and lower extremity motor systems, assessment of coordination, Romberg testing, and testing for pronator drift. This video begins with a brief overview of health history taking, followed by examination of the sensory system, including assessment of pain, temperature, light touch, and vibratory sensations, as well as position sense and discriminative sensations. Anatomy of reflexes, grading reflexes, and assessment of reflexes. We conclude the video with tips on describing your findings. You will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you'll record the patient's chief complaint along with common or concerning symptoms. Common or concerning symptoms relating to the nervous system and specific to the sensory system and reflexes include numbness or abnormal or loss of sensations, and increased sensitivity to pain. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. To prepare for the sensory system examination, let's review its basic components. The sensory system includes the sensory receptors and nerves, sensory tracts in the viscera and limbs, the spinal cord, the thalamus, and the sensory cortex of the brain. To help localize neurologic lesions, the body may be mapped into dermatomes, which are skin bands innervated by sensory roots from different levels of the spinal cord. When assessing the sensory system, plan to evaluate the patient's sensations of pain, temperature if indicated, light touch, vibration, position, and discrimination. Begin the sensory examination by assessing pain sensation in arms, legs, and trunk. To do this, first warn the patient, then use the sharp end of a broken cotton swab stick, a previously unused safety pin, or some other suitable tool. Ask the patient to close his eyes. Then, starting with the arms, test scattered areas, occasionally substituting the blunt end for comparison between sharp and dull. Compare sides and distal and proximal areas. Continue the evaluation of pain sensation with the legs.
Sharp. Dull. Sharp. Sharp.
Next, test the anterior trunk.
Now I want to fold your gown down. Just scoot up a little bit here. Pull your arms out of it. Okay, put your arms right back here at your side. Same thing, just tell me sharp or dull.
If you detect any abnormalities, evaluate the posterior trunk.
Dull.
If pain sensation is abnormal, test the patient's response to temperature.
Sharp.
All right, good.
Next, assess light touch with a cotton wisp. Check the patient's arms and leg.
All right, close your eyes again. Now I'm going to touch you with this cotton swab to check light touch. If you feel it, you say now. Are you ready?
Yes. Now. 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 Now.
Then check the
Now.
patient's trunk.
Now.
Does it feel the same
Compare sides.
here and here?
Same.
Is this side the same as this side?
The same.
And compare distal with proximal areas.
Same as this?
Same.
And this? The same as this?
Same.
Next, assess vibratory sensation using a lightly vibrating low-pitch tuning fork.
All right, I'm going to test vibratory sensation next. Close your eyes again.
Have the patient close his eyes, then place the vibrating fork firmly over the finger pad
What do you feel?
and ask the patient to
Vibration.
tell you what he feels. Ask the patient to tell you when the sensation stops. Then stop the vibration.
It has stopped.
Okay,
Now test the patient's other
right
hand.
over here.
Normally, vibratory sensation is intact distally. If it is diminished, proceed to more proximal areas, such as the forearm.
Okay, now.
When assessing vibratory sensation of the lower extremity, start with the big toes. Compare size. If vibratory sensation is diminished, check more proximal areas.
In this foot, you feel
Keep in mind that distal vibratory sensation may normally decrease with age. For the next part of the exam, test position sense.
Next, I'm going to test position sense in your feet.
Hold the sides of the
and in your
patient's
hands.
big toe with your thumb and index finger. Avoid touching the other
I'm gonna
toes.
Move it up,
First, move the toe
Down.
up and down,
left.
identifying each
or
position
right.
as the patient watches.
You close your eyes and tell me
Next,
which direction it goes.
ask the patient to close his
Up.
eyes and identify the direction
Down.
of motion.
Left.
Move the big toe up
Right.
and down in an
I'm gonna do the other
irregular
foot.
sequence. Then compare with the big toe on the other foot.
Same thing. Are you ready?
Yes.
Here it comes.
Up. Down. Right. Left.
Left.
In a similar fashion,
and then
again with the
right.
patient's eyes
Close your
closed,
eyes.
test position sense in the upper extremities using a finger on each of the patient's hands.
Down. Left. Right.
Finally, Test discriminative sensations by assessing stereognosis or object identification, which is the primary test. If necessary, also test number identification, 2-point discrimination, point localization, and extinction. You will perform each of these tests with the patient's eyes closed.
Keep your eyes closed. Now hold out
To
your
test
right hand.
stereognosis, place a familiar object in the patient's hand and ask him to identify it.
Feel that object and try to identify it.
It feels like a coin.
Good.
Repeat the procedure on the other hand using a different object.
Feels like a key.
Good. You can open your eyes now.
To test graphesthesia, or number identification, use a blunt object to draw a large number on the palm using a single continuous stroke.
Now I'm going to test number identification. Close your eyes. And on the palm of this hand, I'm going to write a number facing you, like on the chalkboard. You tell me what it is.
The number should face the patient, not the examiner.
3.
Right.
Test one palm, then the other.
Now the same thing in this hand. Tell me what this number is.
A 5.
2-point discrimination is tested by asking the patient if his finger pad has been touched in one area or two. Using two ends of an opened paper clip or the ends of two pins, repeatedly touch the patient's finger pad with the 2 points at the same time and with 1 point occasionally. Be careful not to cause pain.
Is this paper clip? I'm going to touch your
Ask the patient to identify if he's being touched with 1 or 2 points.
2.
Then reduce the distance between the points
All right, close your
so
eyes.
that you can determine the minimum distance at which the patient can identify 2 points. On the finger pad, the distance should be less than 5 millimeters.
2. 1.
I'm going to do another test of sensation now. Let me fold
To
you
test
down.
point localization, touch a point on the patient's skin. Then ask him to open his eyes and point to the place touched.
Put your hands right here. I'm going to touch you on a part of your body with your eyes closed. After I do, then you open your eyes and point to where I touched you. Are you ready?
Yes.
All right, close your eyes. Okay. Where did I touch you? Close your eyes again.
This test is especially helpful on the trunk and legs.
Where did I touch you? Correct. Okay, close again. Where did I touch you? Now I'm going to touch you on your left side, your right side, or both. And you tell me whether it's left, right, or both.
Okay.
Ready?
Yes.
Close your eyes.
To test double simultaneous stimulation, use your fingertips to provide stimulus on either one area of the patient's body or in two areas simultaneously. Normally, the patient should be able to identify whether your stimulus was on one side or on both sides.
Both.
Good.
Before we assess the deep tendon reflexes, let's see how and where they occur. Deep tendon reflexes are involuntary monosynaptic cord reflexes arising from the stimulation of partially stretched muscle fibers. This sudden additional stretching sends impulses along afferent nerve fibers to synapses in the spinal cord. Then efferent nerve fibers carry the impulses back to the muscle fibers, causing them to contract. Interruption of these monosynaptic arcs anywhere along their paths will cause loss of the reflex. Each deep tendon reflex corresponds to a specific spinal segment. The ankle reflex primarily relates to S1 and L5. The knee reflex to L2, L3, and L4. The brachioradialis to C5 and C6. The biceps reflex also to C5 and C6, and the triceps reflex to C6 and C7. Note that these ascending reflexes follow the numerical order 1 to 7, which may help you remember them. When assessing deep tendon reflexes, grade them on a scale from 0 to 4 plus. A grade of 0 reflects the complete absence of movement. 1 plus indicates a somewhat diminished reflex that shows movement only with reinforcement. A 2 plus reflex shows greater movement than 1 plus and is an average normal response. A 3 plus reflex is brisker than average, but not necessarily abnormal. A 4 plus reflex is a very brisk hyperactive response. It is accompanied by clonus, a rhythmic oscillation between flexion and extension. Hyperactive reflexes suggest central nervous system disease. Begin assessing deep tendon reflexes by testing the biceps reflex. The patient's arm must be relaxed, partially flexed at the elbow, and positioned with the palm down. To stretch the muscle, depress the biceps tendon with your thumb or index finger. Strike your thumb or finger briskly with the reflex hammer. You should feel the biceps muscle contract and see flexion of the forearm. Here you see a 2 plus response. To assess the triceps reflex, flex the patient's arm at the elbow with the palm toward the body and pull the arm slightly across the body. Strike the triceps tendon above the elbow. Watch for contraction of the triceps muscle and extension at the elbow. Here you see 2 plus responses. To elicit the supinator or brachioradialis reflex, the patient's forearms should rest on the lap with the palms down and externally rotated slightly. When the patient is ready, strike the radius 1 to 2 inches above the wrist. Observe for flexion and supination of the forearm. Again you see 2 plus responses. If you need to accentuate or reinforce arm reflexes, ask the patient to clench his teeth throughout the testing.
Now I want you to clench your teeth together hard when I say, just as I hit the reflex. Ready? Clench your teeth. Relax.
To test the knee reflex, locate the patella tendon in the patient's flexed knee. Briskly tap the tendon just below the patella. Feel for contraction of the quadriceps and look for extension of the knee. This patient exhibits a 2 plus response. To test the ankle reflex, extend the patient's legs somewhat at the knee. Dorsiflex the ankle and strike the Achilles tendon. Feel and watch for plantar flexion. A 2 plus response is seen. Repeat your assessment of knee and ankle reflexes on the opposite side. Dorsiflexion of the big toe, or a positive Babinski's sign, is a pathological response which, as simulated here, manifests itself in dorsiflexion or upgoing of the big toe in conjunction with fanning of the other toes. To test for plantar response, stimulate the lateral aspect of the sole of the foot from the heel to the ball, curving medially across the ball. Use the lightest stimulus that will provoke a response. Note this patient's normal response, plantar flexion or downgoing of the toes. If the leg reflexes are symmetrically diminished or absent, use reinforcement.
I want you to put your hands together like this. When I tell you to pull, then pull hard. But wait till I say.
Have the patient lock his hands and pull just as you test the reflex.
Now relax.
If leg reflexes seem hyperactive, test for ankle clonus. To do this, move the foot up and down a few times, and then sharply dorsiflex the foot. While holding the foot in dorsiflexion, look and feel for sustained rhythmic oscillations. A few beats may be normally present. For a patient who cannot sit up, all of these tests can be performed with the patient lying down. Biceps reflex, triceps reflex, brachioradialis reflex, knee reflex, ankle reflex, plantar response, and ankle clonus.
I want you to lie back on the table now, please.
To test the abdominal reflexes, place the patient in the supine position. Lightly but briskly stroke each side of the abdomen above and below the umbilicus. You should see contraction of the abdominal muscles and sometimes deviation of the umbilicus toward the stimulus. If you suspect meningeal inflammation, test for meningeal signs. With the patient lying down, place your hands behind the patient's head and flex the neck forward until the chin touches the chest if possible. There should be no resistance or pain. As you flex the patient's neck, watch his hips and knees. Normally, they should remain relaxed and motionless. Hip and knee flexion with this maneuver is a positive Brzezinski sign. Finally, flex one of the patient's legs at the hip and knee, and then straighten the knee. This action normally produces discomfort behind the knee during extension, but should not cause pain. Pain and resistance to knee extension is a positive Kernig sign. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include sensory, pinprick, light touch, position, and vibration intact. Reflexes, 2+ and symmetric, with plantar reflexes downgoing. To summarize, the examination of the sensory system includes assessment of pain, temperature, light touch, and vibratory sensations, as well as position sense and discriminative sensations. Examination of the reflexes includes assessment of the biceps, triceps, brachioradialis, knee and ankle reflexes, and assessment of the plantar response, or Babinski's sign.
Thank you for watching attentively to this video.